Good evening
So,
and welcome to another edition of the Amasi Online CME, the every monthly meeting which the Association of Minimal Access Surgeons of India, holds to bring out new aspects of laparoscopic, robotic, and other aspects of general surgery. Today, we have a very eminent speaker, Dr. Rajinder Parshad from the All India Institute of Medical Sciences, Delhi. He has a wide experience of all types of surgeries, and he was one of the very early adopters of robotic surgery, much earlier than others do. Many of you would not know that AIMS already has a robotic surgery training center, probably the first one in the government sector in India. And he has been instrumental in training a lot of other surgeons also in the finer nuances of robotic surgery. To moderate today's session, we have Dr. Hemant Nadia. He's a professor and head of the Himalayan Institute of Medical Sciences, Jolly Grant, Dehradun, a very pleasant area. Welcome, Dr. Hemant.
good
Dr.
evening. Good evening.
And Dr. Arun Kumar ML. He's the professor of surgical gastroenterology at the Sri Gokulam Medical College and Research Foundation, Trivandrum, another beautiful place. Welcome, Dr. Arun Kumar.
Thank you so much.
Dr. Roy Patankar will be joining later. He is a well-known surgeon from Mumbai. He is a director of the Zen Super Specialty Hospital, and he'll be joining later to give his opinion. Dr. Rajinder Prasad, the the podium is open for you for your comments.
Thank you, Dr. Rajdeep, for a kind introduction, and it's nice to be amongst all of you. And when Dr. Rajdeep asked me to give some presentation, then I thought robotic is the in thing nowadays, and maybe we can speak on that. So, with your permission, I can start.
Yes, sir. Please go ahead.
Sure. So, the title of my talk is Emerging Trends in robotic surgery, more so for the general surgical procedures that we do here. And now, if you look at this graph, this is a publication from JAMA in 2020. And this shows that the use of robotic surgery has increased about 9% in the first 4 years after hospitals began performing robotic surgery. And its use was associated with a slight decrease in traditional laparoscopic minimal invasive surgery in some hospitals. The yellow graph is that of laparoscopy. The blue one that you can see is of robotic surgery. And amongst the various procedures, you can see there is a wide variety of procedures which have been done using robotic platform. But the maximum jump that has come in hernia surgery. And you can see here there is a 41 and 44 fold, not percent, 41 and 44 fold increase in the use of robo for hernia surgery. Besides this, there has been a jump in other forms of surgeries also. Uh, this is this is from another paper which shows that even in colorectal procedures, the robotic platforms are being increasingly used. You can see here the robotic one going up, and the open ones are kind of planned open surgeries are kind of coming down. The laparoscopy has kind of held its place, but the open surgeries have definitely started showing a downward. Another paper to kind of uh, give an overview about the robotic procedures, but some common procedure like cholecystectomy, ventral hernias, inguinal hernias. And this is from US Veterans Hospital, Veterans Health Administration. And it shows that there is almost 5 to nearly 9-fold difference in adaptation of these procedures through robotic platforms. This you can see here. Between 2015 and 2019, the difference, there is a 7 to 9-fold increase. Amongst the all general surgical procedure, you can see from 2015 to 2019, the robotics have gone up. laparoscopy has held its place and open have come down. This is for cholecystectomy per se, although sometimes one wonders whether it is the platform which one needs to use for cholecystectomy. This is for ventral hernias, where actually there has been a lot of increase, and so is true of inguinal hernia. Now, if you all of you are very familiar with the fact that inguinal hernia surgery, laparoscopic, has not been taken up as much as the cholecystectomy did. But with robotics, people have started using this for, and you can see the adaptation of robotics, the dark greens being the highest percentages. From 2015 to 2019, there has been a very great increase in US, the adaptation of robotic procedures. This is again a similar thing, which is talking about laparoscopic open and robotic surgeries, and why it is happening, and these are the advantages that are being proposed. Now, what I'm saying when I say proposed, because this is what is generally talked about when people are being convinced about robotic surgery, that from a surgeon standpoint, better surgeon control, stability, vision, and greater degree of movement, precision, and it's also comfortable to operate through robo. Uh, Whether it has translated into a patient benefit is yet to be seen. And we will talk a little bit about some of the common procedures, particularly the ones which we have been involved in. And we'll also talk a little bit about the literature. Uh, Not a exhaustive review, but more recent kind of literature. I have tried to put some representative slides because in the early days, if you start talking of the older literature, then people say, no, that was a learning curve period. But now it has been in use for quite some time, and more recent publications perhaps reflect the current day, scenario, and people have overcome learning curve, and now they are publishing, and we need to see where we stand with respect to more recent publications. Most of the earlier publication did not show that it translates into a patient related benefit. This is the kind of spectrum of cases we have had our experience with, although we have had a limited access to robo because it was largely with urology. But since last year, we have had it in our own department, and the number of procedures now are definitely increasing. And you can see this is the wide spectrum of cases that personally we have been involved in performing through robo. We have, you always start with gallbladder surgery, but I have skipped that because I guess that's a very preliminary thing. And the next thing that one starts off when you're in the beginning is the hernia surgery, and you can here see a TAPP being done. Now, from a surgeon standpoint, what all of you must be doing all these procedures and quite proficiently too. But what is striking is the stability of vision, and I'll probably keep saying that for most of the surgeries that I show you. The I guess biggest advantage is stability of the vision. But then you see the cost of instruments is very high in robotics because every instruments after 10 counts, it kind of becomes defunct. But if you leave aside that part, because you will probably have to use sometimes more than one instrument, for example, in a direct hernia, we may be able to do this all with one instrument. Like here, I'm using a scissor. But if you have large indirect hernias, when it comes to separation of the cord structures from the sac and all, then scissors is not a ideal thing. I mean, you can injure, and then you need to use another energy source. Like here, you must have seen I was using a bipolar forceps, and then of course it helps you to kind of maneuver things into these slightly difficult to access places, and there is no doubt in anybody's mind that suturing is definitely big plus. Now here, as you can see here, that instead of tackers, we are using sutures to, kind of hold the mesh together, both on the medial side as well as the lateral side. And we also used it to target to the Coopers in this particular patient. And then you can, of course, close this peritoneal flap very nicely, because that is one of the most tiring part of the TAPP surgeries. Then ventral hernias. Again, you can see this is a patient who had this ventral hernia. You can see the colon going up into the defect, and he was a large, hefty man. And now here, I think, working on the roof, everybody gets tired, and that is why I think IPOM got very popularized, because it was it was a little easy to kind of just put the mesh there and fix it up. But you can see with the robotic platform, working on the roof is definitely a easy task. And here you can see we are, once we have delineated the defect, reduced all the sac and all, we thought, okay, this may be a good time to do ventral tap. And you can see this being done, and you can, I'm not getting too much into the details. It is more like giving you details of the technique and all, because I guess you're all familiar with it. And but the idea is to just give you a glimpse of how one can maneuver and maneuver into these places, and kind of create a decent space, and then pull the sack down. You first go around the thing as much, and then you eventually get the sack down, and then here you have your defect. And then you can nicely suture up the defect. If there is an associated divarication, you can try and correct it too. So here you can see all this being kind of easily sutured. Now there is a, particularly in Da Vinci, there is a facility that you can kind of turn the view upside down, and it will give you a feeling as if you are suturing on the floor rather than on the roof. But personally, I have not used that facility, because I find that is doable otherwise also. And then again, all these large flaps that we have created need to be put back, and that can be done very nicely through this platform. Now, if we look at some of the recent papers, this is a 2025 paper, and this kind of did a propensity matching of inguinal hernia repair, and from 2007 to 2022, which means you have recently performed surgeries also, and they, of 3,000 plus patients, they found that 420 matched, and they had 140 in each group, open lap and robotic. 2.4 years was the minimum follow-up they had. What they noticed in this review was that patients who had undergone open repairs had more comorbidity and more of recurrent hernias. And this is so what they concluded was there was no difference in SSI, seroma, hematoma, readmission, and recurrence. They found that robotic had slightly higher median operative time, and of course, the cost as of today, unless the cost of robo and its accessories come down, there is no match. And this is what they concluded. So this is one of the recent papers. Depending upon the parameters you are trying to assess, you will have your results. So these were the parameters they were looking at, and the other interesting thing they noticed was there was a slightly higher frustration level with robotic amongst the surgeons. So these are the, when we talk of evidence, this is what the evidence is saying. And this is another updated systematic review and meta-analysis published in 2021, 9 articles, only one. Surprisingly, we are not having too many RCTs going on, because I think people are just adapting to it, and I think there is a reluctance to do RCTs. And amongst the 64,000 patients, there were 7,589 robotic hernia repairs. More unilateral hernias were performed through lap, what they concluded was, again, no difference in outcomes and longer operative time with robotic in single side hernias. This is the conversion and all were kind of okay. Coming to ventral hernia repairs now, there was this prove it randomized control trial, 75 patients, 39, 36 robotic laparoscopic. Period of study being 2017 to 2020. And they compared IPOM and their follow-up was more than 30 days and they chose patients with less than 7 centimeter defects. So these are their outcomes. And if you see this red thing there, most of the other things did not change much. And eventually they concluded no difference in complications, pain, quality of life, of course, higher costs with robotics. Another one in 2024, 65 studies, 2,460 patients underwent robotic repair. And they compared all these three tabs, right tab, robotic tab, IPOM, ETAP, TAR, and TARO. Everything was included in this thing. And so since they were comparing both robotic lap and open, they said that as far as open is concerned, there is less SSI, lower mortality, reduced hospital stay, but they found higher seromas and longer operative times. Compared with the robotic TAR with open TAR, now these are more complex hernia surgeries, more complex operations than IPOM. They again found lower complications with the robotic TAR and but higher uptime, but no difference in the length of hospital stay. With respect to laparoscopic, they found higher uptime in robotic and of course higher costs of the robotic. So this is what the evidence is. Now let's move on to the other GI, some of the GI uses of robotic surgery, and this one is first one that we kind of have tried it on is achalasia cardia. And this is a case scenario, 50 years old male, dysphagia, card of 7. This is a manometry which shows panesophageal pressurization, type 2 achalasia cardia, and this is the barium swallow of the patient. And this is the usage in a something which we have been very regularly doing laparoscopically. And this is a small glimpse of the video. The procedure is almost same. The port positioning is slightly different from the laparoscopic. And the other difference that in my own personal practice I have is that I will keep the endoscope in the stomach when I am performing this procedure, whereas when we are doing laparoscopy, we do not keep the endoscope in the stomach. We keep it a little behind, above the G junction, and bring it down, use it later to check for the leak and, distensibility. And you notice that, again, you will notice a very, very stable vision. Otherwise, you are always jostling with your uh, first assistant in laparoscopy and asking them, idhar dikhao, udhar dikhao. And that is the anterior vagus that we have preserved, and here we using hook. Now, if you notice, unlike in I don't use much of a shearing technique anymore for even laparoscopic ventral hernias, except that I may use it just to create a half a centimeter of initially, just to kind of get to expose the submuscular plane. And what you can see is the endoscope is there, which keeps the uh, esophagus and stomach stable, because here you can see that we have we are using 4 ports. One of the port is stabilizing has pulled down the stomach, and the other two are the working ports. And though we do put a assistant port, but it's a little problematic for the assistant to work through that narrow space. And when you are doing these kinds of procedures, there is always he does help in passing the sutures needle. Now, once you have completed the myotomy, you can see here the endoscope being brought, it is taken back and then it is again insufflated to check for leak and other things. And finally, we conclude the operation with the fund application. And in most of our cases now, we are doing angle of accentuation unless there is a esophageal perforation, which fortunately in our own hands now for last, we had one recently, but that was almost after 200 cases where we did not have any perforation. So in total of about 400 plus cases, we have only had 4 or 5 kind of uh, esophageal perforations. So that is one thing which I would like you to remember when we talk about literature, because the literature talks about, there is a this is a systematic review published in Disease of Esophagus. Now it had 6 articles, 171 lab, 189 robotic. And this is what they concluded: no difference in op time, blood loss, conversion, length of hospital stay, and long-term recurrence. Uh, but they did found that there were higher intraoperative perforations with laparoscopy. Now, what surprises me is that this is a multi-center study, but there were almost 25% perforation rate with laparoscopy, which I think is too high. So I guess we have to take that. But as of today, this is the evidence that with respect to other parameters, not much, but they say that you have lower perforations. This is again from a UK study. Short term, they were looking at short term complications, peri-op outcomes. And although it's supposedly a high volume UK center, but there were 13 patients who underwent robotic HCM and did not have any perfs, and they were all discharged quickly and had a good outcome. And they said that it's a safe procedure and may be superior to laparoscopy. It is yet to be seen though. And the other application of robotics has been in gastroesophageal reflux disease. And this is a representative case. You can see the details here. Upper GI endoscopy shows a Hill's grade 3 with a 4 centimeter hiatus hernia and a very high D-Mister score. Manometry, type 2 EGJ, and ineffective peristalsis 50%. This is the barium solve. Now, I'm not showing you too much of detail here because most of it, what you do is similar to what you do at in achalasia, similar ports and similar initial dissection. And here you can see that what we are using here is a bipolar. Sometimes you use what is available to you, and at least on the look of it, it doesn't look like a very big hiatus hernia, although endoscopies had reported it. Now you again see that stable vision going into the mediastinum. It's a little more easy to go into the mediastinum, and you mobilize the esophagus as much as is necessary to get a 2 to 3 centimeters of the intra abdominal length of esophagus. Now, if you can't achieve that, now here you can see a retroesophageal window being created, and then you will gives us a sling to allow us to put a sling with which we can pull it down. The fourth arm or the assistant can pull it down, and then once you have sufficient length, then you do all this classical. In this particular patient, we could have even done a Nissen nicely, but we chose to do a toupee because of the associated motility issues. We do talk and discuss with the patient, explain it to them that if they are very volume regurgitants, then I still would prefer to go and do a Nissen. But if their major complaint is heartburn and all, and they are okay with a little bit of, they have to balance it out. No, this is what the sages recommendations also say. They have, you have to balance out the post-ops uh, downside, the side effects of fund duplication, particularly when you're doing a lot of mobilization and all, and you have to balance it out with the benefits. So, and here you can see the toupee now being done. whereby we kind of fix to the esophagus, the sides of the wrap are fixed to the esophagus. And of course, all this becomes a little comfortable. I mean, there's no denying that it's much easier for the surgeon to do this. And then kind of, you can see here, this is being done. What does the literature say? The literature, this is the Journal of Robotic Surgery 2023. And you have 7 papers, majority of them 10,000 plus patients, 8,000 plus have undergone laparoscopic repair and about nearly 2,000 robotic. They said that there are lower post-op complications with robotic and the length of hospital stay reduced by 0.68 days. Whether it matters clinically, it was statistically significant, but I don't know, 0.68 days. Rest of the parameters, op time, intra complication, 30-day readmission, they did not really change very much. So this is what the literature says. And again, a 2024 publication, comparative analysis of robotic and lab techniques in hiatal hernia and crural repair. So they compared robotic techniques to the established 13 papers reviewed till 2022. So op time, they found 88 to 196 minutes with robotic and 102 to 145 minutes with lab. Recurrences were 1.8% with robotic and 1.2 with lab. Now, blood loss 20 ml, 50 ml, it doesn't really matter very much, even if it is shorter stay and fewer complications for robotic surgery. 6.3 versus 19% with lab. Now, this is definitely significant, and they concluded that despite the lack of striking differences, robotic hernia is a valid and evolving approach. This is how authors have concluded. Uh, now we'll come to more complex scenarios, complex surgeries. And here is a patient who is undergoing a recurrent hernia, who presented with a recurrent eclasia. He had undergone a lap feller at another place. And then he had problem, again underwent a dilatation. For some time he was okay, but again he recurred. So then he came to us, and this was his Eckhart score. This was his barium, as you can see, a kind of ballooned out anterior part of the mucosa and narrowing there. And we did them, they were not able to get the manometer across. 2-3 times I think they attempted and they were not able to do it. Endoscopy showed some resistance there. And then we told him the pros and cons. We had done a CT. I'm not projecting it here, but CT was also done, which confirmed nothing else, no pseudoecclesia. And this is how it was. And now you see, this is a, so naturally, now this patient had not had any anterior fundoplication. So unless you're doing a door fundoplication, whether you do a toupee or a angle of face or do nothing, this patient had had no anterior flux procedure done. Yeah, you are always afraid that mucosa is going to be stuck here. And so you have to be very careful. The major part of your surgery here is to define the anatomy, what is what, where it starts and where it ends. And you can see this right crust, and now having separated a little bit from the liver, that was the first challenge. We have to separate it all from the liver, and since you've seen, we knew from CT that there is a, in fact, they had reported it to be esophageal diverticulum. But when we discussed, we knew that it is because there is a distal obstruction, and whatever myotomy they may have done is now causing the proximal esophagus to distend and dilate. So now you see that we have somehow recreated a little bit of normal anatomy. You can see both right, left crus, but you don't see much of an esophageal muscle above into the mediastinum, right? And that is what has been my experience in all the redo cases. What I have seen is that people stop short at G junction They do a esophageal myotomy, but nothing is done. The gastric part is left out, and that is why they have problem. Whether it's dilatation, whether it is pillar myotomy. And now you can see here that we did go up a little into we kept doing intra-op endoscopy just to make sure uh, that we don't kind of go through the mucosa. And then we realized that there was nothing on the stomach. The myotomy had been restricted to esophagus, and then the rest of it was largely devoted to creating a gastric component of the myotomy, as you can see here, being done. And then uh, you can see here slowly and slowly we divide these, and we basically what we have to connect is the esophageal myotomy with the gastric myotomy, and that junction was a little crucial bit. The rest of it on the stomach side, since it was largely a virgin area, since they hadn't done anything here, it wasn't too bad a situation. So we were able to, you can see here the hook being used nicely to do that. And you have these very small oblique fibers. Now you can see, if you remember the earlier case, the esophagus has very transverse and circular kind of fibers. And as you come down on the stomach, the thickness decreases. They are barely, very, very thin fibers, and any aggressive movement can lead to perforation. That's why you have most of the perforations on the stomach side. And once we thought we had done the job, then we again did an endoscopy, check endoscopy, rule out any micropuffs to see whether air is nicely insufflating into the stomach. Once we have ascertained that, now in this patient, you also see a slightly widened hiatus. 20-25% of our patients who have achalasia also have a wide hiatus. We do close it, though not as tight as one would do in a if you're doing a GRD, because there, if you do it too tight, then there is a risk of dysphagia in these patients, and that is what they have come to you for, and then they will not be very happy, and you will also not be very happy with it. And having done that, then you kind of finish the whole thing with the. So you can see here, you can take the sutures with right hand, left hand, and it gives you that dexterity to work around uh, more than the other thing. This is another interesting case, which on all the evaluation that was done, a 49 years old who kept having these vomiting for nearly 1.5 years after food. And if you see there, the stomach is totally turned upside down into the mediastinum, and it was thought to be an upper GI. They were pretty confused. They said that's a combination of sliding and paraesophageal hernia with some reflux-related esophageal ulcers. And we went in with the kind of. I just want you to have another look. You see, the stomach is almost up into the mediastinum, and the pylorus was almost. So we went in with the idea of that is probably a paraesophageal hernia, and then we expected that okay, fine, we can get it down and then see what we can do. But when we entered, it was quite a different story. It wasn't like a virgin abdomen, first time kind of a thing. And you see all this momentum, everything was stuck. There was no clear anatomy. It's not like the usual large paraesophageal hernia that you see where. So this surgery lasted almost 5.5 hours. And it took us a lot of time just to clear the anatomy. What I'm showing you is after we did manage to clear up some of the things and get an idea as to what is what. And here you can see the cementum was stuck there, and we couldn't see the stomach much, and then therefore we had opened up that uh, the plane between perceive so-called the stomach and the colon, and we found the backside of it, but it won't just budge from there. And then we thought, okay, let's go into the hiatus and see whether it is actually a paraesophageal hernia. And here you can see we are up into the mediastinum. The right crust, the left crust have come into view, but you don't see any stomach there. So we realize that it is actually not going through the hiatus, and it is probably going through some opening in the diaphragm by the side of it. So this made us a little more conscious, and then we did some further adhesion lysis, and then we were able to finally we were a little more bold now, and we were able to then see that, okay, where the stomach is. But it wasn't easily coming down, so we did some more dissection and divided some more addition, and now you can see the whole stomach, which has gone up, is being pulled down. And you see now the anatomy was totally upside down, and then we were now more confident of doing it more boldly, because we knew where the stomach is, and we had to define the boundaries of the defect, and we also had to separate the stomach. Now part of the stomach and the sac is still inside there, which was with painstaking dissection, careful dissection was brought out of that hole, so that we didn't want to injure it. And you can see this. Let's move it a little forward. I think there's some. And then we were able to create this retroesophageal window, and we still have some bit of it left. So here we are kind of removing that. And finally, this is the anatomy. We found that you had a paracardiac kind of a defect. It was just outside the uh, left crus, or so uh, we wanted to put some absorbable or biologic. We didn't have it. Patient is a poor patient. We didn't even have a vicryl mesh there. So we had to kind of do some improvisation, and fortunately we were able to close that defect. First we did that, and then we went and took the whole wall together, and then did the posterior crural repair. Since our problem was not reflux, we weren't so much worried about an anti-reflux procedure in that sense, but we did want to hook up the stomach and cover, so that it remains with the esophagus. So we used that angle of his thing. That was the best that came to our mind at that point in time, that this may be the best bet, since her problem is not reflux, it was more of vomitings because of the thing. And then we checked the anatomy that everything is fine, didn't drop endoscopy, and then kind of got away with it. Patient did well. She's under follow-up and fortunately is relieved of her symptoms. We did a contrast study on day 2, allowed oral liquids on day 3, discharged on day 4 on a semi-solid diet, and she's right now reasonably doing well. And the SI does give you advantage of working in multi-quadrant spaces, and this is an example where we had this 20 years old lady with the right upper quadrant pain for 10 years. Physical examination normal, ultrasound suggestive of a cyst, colorectal cyst. And you can see on MRCPA, very large cyst. These are the intrahepatic ducts, which are kind of normal, but just after that, and the gallbladder is also very long in this patient. So we thought, okay, let's try out a robotic approach in her. So as in any other case, initially you look around, try and define what is what. And as you can see, the gallbladder is so long, it's stuck to, the inset kind of shows you how we placed our ports. And once we had that, and you can see the colon is stuck there, the duodenum is stuck there. So initial thing is, in any surgery, what I teach my students also is that your first aim should be to define the anatomy. However time it takes you, but first thing is, don't jump onto the target organ. You first define your anatomy. You have to preserve the important structures, and that should be your first aim. What you want to take out, even if you end up injuring it, it's fine, but you should not injure the structures which you have no business to injure. So as you can see here, once we got the duodenum down, the colon down, and you see the gallbladder is so long, and it's going so way up, and the fourth arm is kind of retracting the gallbladder up. We are working with 2, and we also have an assist port. And it's not only, and now you can see the cyst has been kind of defined a little. You can see a very, very large cyst here. The gallbladder is also, the cystic duct is all huge and curving around. And this is the duodenum, where right next to it, we are and we have to separate it from the on just to the left of it, to the patient's left would be a hepatic artery, and behind it would be the portal vein, and you have to safeguard the duodenum. You have to define the boundaries. So once we had some reasonable clarity as to okay now what it looks like, initially it wasn't even clearly visible. Then we thought, and this is the posterior dissection. You can see the IVC there, and again you can see it's so close to the duodenum here, so you have to kind of uh, separate it out so that we don't injure anything uh, in these patients. It's a very large political cyst. I think it's one of the largest that I have done, even when amongst the open cases that I have done. So this is how we kind of, and then we decided, okay, let's now get the upper end. And then for that we needed to get the gallbladder down because it was a little tedious. Now, once you have problem, then you have other problems also. In this case, the right hepatic was coursing anterior to the CBD, and we have taken down the cystic artery here, and then we are trying to see how big the cystic duct. And so once we got the cystic duct junction with the CBD, we thought now is the time to go down further. Many times I've seen people just dividing at the upper edge of the duodenum, the colloidal cyst, but that's not correct. You should always carefully see the MRCP where the pancreatic duct and all is, and try and stay above it. And but you do have to get to the normal looking CVD, and you have to go into the pancreatic part. You can see here the pancreas now coming in view. We are almost in the intrapancreatic part of the CVD here, and finally we were able to. You can see it has the cyst has finished there, and below here is the normal looking duct, and here we can clip it, divide it. Once you do that, then you can dissect it off the underlying structures, which would be your portal vein and all, and try to stay close to it, not too close, but close enough so that you don't uh, end up hitting the more critical vascular structures there. I have even had a aberrant artery going through that area, and it wasn't identified preoperatively, and suddenly you realize that you cut it, and that kind of a thing we don't want. And once we have clearly identified the junction, we are almost at the hilum now, and then you decide to open it. Uh, we don't want to open it right up. You can see that right hepatic going up there and has been the cystic artery coming from there has been clipped. So you always divide a little lower down and then make sure that you divide enough, but to leave you a stump which can be sutured. So this is what it is now. You can see the bifurcation there, and you have enough tissue to suture it up. And just above that is your hepatic artery, and you don't want to fiddle with that. It's not to give you any additional benefit. So then next is creating the hepatic duodenostomy. So we measure it, measure the length about 40 centimeters or so from DJ, create a hole in it, and create a rule limb. Now you can get lost, so it's always good idea to mark your proximal the pancreatic limb and the distal limb so that you don't kind of twist it around. And so here you can see we have taken a anterior suture and holding the thing up, and then kind of measuring the how much you want to kind of make a cut. And since the duct was reasonably thick walled and we had a good vision, we thought we can go for a continuous suture using a V-lock here, as you can see. So we took one on one side, the other on other side, other corner, and then we kind of, so this is the posterior layer in progress, and we'll go till the end and then leave it there, and then start the other suture, and then we'll use that too. Now since we have put a stays kind of a suture on the anterior wall, it helps us to keep the lumen open so that we can nicely see it. And then we take sutures, don't tighten them till the time we think the suture has done its job, then we remove that and toward the last here, you can see the other suture is also outside, and this one is also there, and then we tie the two together. This is your hepatic ostomy completed. And then we have to do a jejunostemy, and then you mark the, we have taken it, anticolic here. And this is the jejunostemy, and then you again stitch it up. After you're done with it, then you have to close the mesenteric defect that you'll see here, the mesenteric defect being closed. And that's the end of it. Put a drain and then kind of come out. Now, so then moving on to some other unusual complex cases that we have encountered. This is a young male with epigastric pain, weight loss. Examination was thin-billed. He had undergone ultrasound, upper GI endoscopy, CT scan, CT angio, and which showed actually what you can see here is a narrowing of the celiac axis, and same thing being depicted here, and Doppler showing the flow velocities, which all confirm that patient has what is called as median arcuate ligament syndrome. And since we had ruled out everything, upper GI was normal, ultrasound didn't show any hepatobiliary cause, the CT did not show anything else, and we thought, okay, let's try out, consult him. This is something which is not very common, and it is also not a unifactorial, so you have to tell them that it may work, may not work for you. But since we had a clear evidence of median arcuate ligament syndrome, or Dunbar syndrome as it is called, so we thought, okay, let's try it out. And these are left gastric. So first thing, and this guy had a lot of lymph nodes and lymphatic channels which were around. It's been described also that they can have a lot of these lymphatic channels and fibrolymphatic structure. Now here the assistant is pulling now the left gastric, because we'll use it to trace it to the, and now we are clearing the aorta. About 5 centimeters we have to clear, and these are the median arcuate fibers which are being divided. And now you can see that celiac axis is coming in view. Now this syndrome is not only because of vascular, but there is also a hypothesis that this also entails. Now you can see the left gastric draining there, and you can see the trifurcation, the hepatic, the splenic, and the left gastric all rising from the celiac axis. And you have to make sure all this, because the celiac axis ganglionic fibers are also supposed to contribute to pain, and that is why some people would use a celiac axis block to see whether it gives a temporary relief to the patient. If it does, then they say that chances that it will succeed, this procedure will succeed, are higher. So you can see here a completely cleared celiac axis. Fortunately, patient did well, and he did well, and post-op studies also showed significant improvement. And these are, this is a celiac axis compression syndrome reports which have shown that robotic approaches can be used. And this is a study of 74 patients. In recent SAGES conference, they had a session on this, special session on rare diseases, and it was interesting to see that there's a lot of debate as to some people are of the view that it is missed a lot because of the vague symptoms, and some, therefore we should more aggressively evaluate them. But everybody also admits that it's not a unifactorial thing, and people, you cannot expect a 100% kind of a relief. The longer you follow up, you may see more recurrences also of the symptoms. So this is 74 patient. At 1 year they felt that 90% patients did report relief. But if you look at a larger, broader publication, larger series, the symptom relief varies from almost 37% to as high as 90%. even 20%. So I guess we have to be keep our fingers crossed, explain to the patient, choose the patients properly, and then only do this. Now, do we have time or shall I stop here?
So we have about 10 minutes.
We still have 10 minutes. Okay. So then some other situations where I think robo can be useful, like in this particular patient, a obese patient who had this lesion right next to the G junction on the lesser curvature. And the CT, the endoscopic ultrasound, it all suggested that it is likely to be a cyst, and patient was quite obese. Now, supposing the same thing was on the greater curvature, it would have been very simple, just do a sleeve and then. But the location of this was such that you cannot do kind of a sleeve on the lesser curvature because your vagus is there, the artery is there, everything goes along there, and plus it was so close to G junction that we didn't know whether it will encroach on the G junction, because sometimes what you see on CT when you actually go and operate, you find different. So we thought, okay, this is a place where we'll prefer a robotic over a laparoscopic approach. And so we did a gastrotomy first to localize the lesion. Once we had the lesion in view, then we slowly went around it towards the, and trying to keep the fat outside. You can see the left hand, we are trying to avoid taking all the lesser curvature fat to avoid the vessels and nerves in there, but also trying to make sure that we get a good margin of the wall. This kind of a thing, I think, may be a little more difficult through the laparoscope. Once we had it all, then we could comfortably suture it up. We, I think, used 2 layers of this V-lock, and again the main uh, advantage being this, uh, you know, you're confident that even if it's a complicated suturing, we should be able to handle it. Even if it goes to, the thing is going to a odd place, we may be able to handle it. So it kind of gives you that additional advantage or additional confidence of doing it. So in situations, considering the cost and all, particularly in our setup, we may not be able to use it across the board for everybody. After initially we do have support and we have accessories, but it's not going to last forever. And we have to also, as a teaching institution, you also have a responsibility to eventually uh, figure out where it is good, where it is not necessary. Like we had our urology department yesterday, we had a conference which finished on Sunday only. And as a policy, they have decided they will not do it for a nephrectomy, adrenalectomy, but they will use it for pyeloplasty, prostatectomy, and things like that, which are more complicated. And this is a paper which has suggested that between 210 and 216, the laparoscopic approach to the cysts, gastric cysts, and even the robotic has risen from, laparoscopic has gone up significantly from 26 to 48%, and the robotic approaches are also being now increasingly used for these kind of scenarios, as you can see here. And the open surgery is now coming a little down with this. This is a patient 51 years old with the shortness of breath and reduced air entry on the right, bowel sounds in the right hemithorax. This is the X-ray, CT scan. All this you can see very well that it's a large, very large Mercagni hernia, and you can see this hernia being reduced slowly and slowly. But sometimes, in fact, most of the times we have seen Mercagni hernia, you put the patient head up and then it all falls out, but not in this patient. We expected that it's going to be very large one and it's not going to come down easily. So once, and you are not going to, you shouldn't try to pull it all. And so we followed the basic principle that you follow, that get the sac in toto out, and then that might make the whole thing easier. And here we slowly and slowly dissected all around the extraperitoneal space trying to get the sac down slowly and slowly. All this manipulation is definitely a little easier with the, and then once we got most of it out, then it all came out nicely. You can see here everything got reduced, and then we took out the rest of the sac, and the falciform ligament was also kind of going up, and that was divided here. And you also need a bit of, and these walls of these defects are not very strong, so I think it's a good idea to use a mesh here. So we got this. Once everything was down, then we created a little bit of a space here along the liver, upper border of the liver, so that our mesh sits in there well. And then the defect was closed using a 1-0 Statafix. And this is a barb suture. All of you are aware of it. And then once the defect is closed, then we put a, now lower part, it's all pericardium, and also you can't really put tacus vacus there. So we used tacus above the costal margin to stabilize the mesh. And since the glue had held the part of the mesh there, then it became a little easy for us to, put some stitches to reinforce it so that it doesn't kind of flip flop. Anyway, this part would, once the abdomen is deflated, would come behind the liver, and liver will probably keep it in place. But still, we wanted to put some additional stitches because you can't put tackers and other things here because right behind is your pericardium. Again, a 46 years old male with the dyspnea on exertion, and this is his diaphragm left, you can see way up. So we decided to go in through the chest. Now through the chest, when you go, it's very difficult to suture because the intercostal spaces are narrow, and it's not easy to kind of negotiate and suture through that. And you can see this very thinned out diaphragm, but on the extremes you had a relatively normal looking diaphragm. So we took a central stitch just to orient everything in place. And after that, it was straightforward thing, just doing application in multiple layers, so that application in multiple layers, and these are the pledgets. And you can see here eventually both sides you can probably see. You have to take not corner to corner bite, you have to include all this thinned out diaphragm in multiple stitches so that everything gets bunched together. If you just take corner to corner, the central part will hang into the abdomen, and you will have seromas forming in it, and then other problems. So this is what you can see here. Robot does give you a little more ability to play around and nicely get the healthy part to healthy part here. Now, if you can't get, sometimes it is all too thin, so in which case you may want to put a mesh. But here we thought that it looks decent enough, and we kind of left it at that. And I think I've okay. So this is the post-op X-ray. You can see here, diaphragm has come down. It will not stay here. Now, let me also tell you that over a period of time, this will still ascend a little, but immediately post-op, it looks pretty nice. But you follow them up long enough. And then other thing is sometimes you have a hypoplastic lung there now, which is not going to expand and fill up the space. In this patient particular, say for example, you should be very careful when you are discussing these CT scans. Ask the radiologist that what is the condition of the lung. These supposedly they should have happened in childhood, and then the lung becomes hypoplastic. It is not going to expand. You pull the diaphragm down, there is a space there. It is going to get filled with fluid. So it's not a very straightforward thing. One has to carefully evaluate these patients, select these patients, explain it to them, then only go ahead and do these things. Thymectomy is another thing which we have. I don't know if you're interested, or we can skip the thymectomy and maybe show you.
So it's 9 o'clock, so I think Maybe you can take some questions, maybe.
Yeah, I'm fine. I'm fine. Whatever you want. We can stop here and we can take questions, whichever way you want. So I think I'll stop here.
Yes,
It's
I
my
think
first time
I
and,
see a question in the chat box from Dr. Kedar Patil asking which company provides the pledgets that you showed for eventration or diaphragm.
we just go ask our CTVS colleagues. We go and steal it from their room. So they probably know where it is. What is it?
Right.
These are pledgets. I think they use it very frequently for valves and these are Teflon pledgets. So
So we use similar pledges. Gore and Company manufactures these, and they're made of PTFE. So you can cut these into strips and use them as strips on the Crura also. If you don't want to use meshes, so you can buttress both the Crura with this PTFE strips, which sir has shown. He's cut into small pieces, but you can cut 5 millimeter by 3 centimeter strips on both Crura also. Rajdeep sir, you want to come in?
So that's okay. I just wanted to comment on the wide variety of cases which Dr. Prasad has shown. And he's talked about the evidence also along with it. It's just not the cases he's shown. So very thankful to him. Now, please, Dr. Padankar, just wanted to introduce you regarding you are the for our upper GI program also for Amasi. So, back to you, Dr. Padankar. Yes, please. Right.
So another question, Dr. Rajinder, is you're using Mercil for hiatal hernia repair, pleuroplasty. Is that your standard practice?
no, it's not. Actually, we used to use Ethibond, but now if we don't get it, we get Silk. We use Silk. But in this
Okay.
patient, I use Prolene because that we didn't have any absorbable mesh and all, and I wanted to use something which is more likely to stay there. So I thought we have used Prolene earlier times also, but although it's more difficult to handle, but I thought it may be a better choice. It's not something you see every day, and in absence of any, I would not put a synthetic mesh there. So I thought, okay,
What
let's
about
use
composite meshes, sir?
composite meshes. We have seen enough of erosions with composite meshes also. So I'm very reluctant if you can manage without putting a mesh. And most of the studies in itis hernias have also not necessarily shown short-term results are good, better, but long-term there are now randomized trials which have not shown any difference. And now
Really,
people
sir, what do you do
are
when the crura are not coming together? You have 6 centimeter defects, a redo case. You can't bring the crura together on suturing.
so in that case, you can give release incisions. See, in this patient, we had a kind of a release incision already, right? It was
Release on the left side. Normally, you do a release on the right side and then
so
cover
you
that
can do
area
either
with
side.
a
Both right and left release are described, and then you do that, and then you put a mesh in that defect. But fortunately, in this patient, it came together. There are other techniques also described, like a vascularized posterior rectus sheath,
Porsche.
those kinds of things. But if you have a straightforward large hiatus hernia, you do that, then you do that, is fine. But you already 5-6 hours into the thing, struggling to find
True, sir.
what is what, and you wanted to add another 2 hours procedure. I think that's not something.
Excellent. I also see that you always preserve that vessel to the liver where the hepatic branch of the vagus runs. That is your routine practice?
It is my routine practice. Unless I'm forced to divide it, I will not. Because whatever
Right.
God has provided, I think we should respect it.
Sure.
And
Sure.
other thing is, I always tell my students, bring the wrap above this. That way you will be on the esophagus.
Right.
If you cut it, then you can wrap stomach around wrap and you will say, oh, we've done a great job. But if you make sure that you are bringing your wrap above that, it will by force will be on the esophagus.
Right. Professor Nautiyal, do you have any questions or comments for sir? I think excellent talk for the huge variety, repertoire of wonderful videos.
Yeah,
sir.
and
Thank you very
thank you, sir, for a very nice presentation. So from all the data you have shown that it has shown that laparoscopy versus robotic, the results are nearly same.
Yes.
And the cost is more with robotics. So in the future, how do you
I have a very interesting slide if you want, allow me to show. It's not a video or anything. If I may show that.
Sure, sir. Sure.
Yeah, sure, sir. So my question, in future, we should restrict this to some particular procedures where robot has advantage, or we
Yes,
should
yes.
market driven to push it,
Yeah,
or
yeah.
of
You
the
see this
demand by
paper?
the patient.
Can you see this?
No, sir. we
No, sir,
can.
you have to share your screen, sir.
Oh, again. Okay, let me see what happened. Okay. All right. Okay. You can see it now?
Yes,
Yes.
sir, you can see that.
Okay. So this is a paper which came out in Annals of Surgery. And there is a recent one which came in Surgery Endoscopy. They are talking about conflicts of interest in robotic surgical studies,
Right.
validating author's declaration with open payments.
Yeah.
So what they have found is in 52% studies had more than one author with undeclared payment received. Only 18% authors declared a conflict of interest. Undeclared payment from Intuitive are more likely to recommend a robotic surgery,
Yes.
right?
I think
And
this is a very telling comment.
yes, right. This is another paper which impact of corporate payments on robotic surgery. So 91% had studies had authors who received a median of 3,364 dollars per study, right? Total of 4 lakh plus dollars for all the studies, and the companies continue to support uh, those authors who are more likely to give positive outcome. See, in this sages meeting also we noticed that I can stop sharing now. uh, this thing was uh, you had study after study being presented and a meta-analysis, systematic review, and everybody said not much benefit, and they always ended up concluding we should continue doing it.
Yes.
So this question was being raised. So I think it's a very good tool for selected scenarios. Uh, so there's nothing, it's like it is a tool in your hand. You use it according to the need. It is a very good tool. But if you get carried away and start no, unless its cost comes so low and that okay, it doesn't really matter, that's a different thing. But it can make you overconfident also and get you into trouble also. So I think we have to be very, very careful as to where we use it and how we use it.
So I think more for surgeon's comfort as much as for patient outcomes. When I do a redo hiatus hernia, I find a robot much more surgeon friendly. Otherwise I tend to get a trapezius spasm by the time I finish a redo
Yes.
hiatus hernia.
Yeah, I don't deny that, but I mean, I had few slides on ergonomics also where they have shown that if you continue doing it, it's just that the areas of your body that get affected change, but it has its own ergonomic issues. That's why most of the people are now switching from close. Most of the new companies have switched from closed console to open consoles
Yeah.
because whatever
Yeah,
studies
I
were done
agree,
with
sir.
Da Vinci,
True,
people had
true.
didn't have leg pain, back pain, they had neck pain, this pain, that pain. Eventually, ergonomics, you sit long hours on a chair also, you get tired.
So we use
So,
a CMR, say it's open console. So it's
yeah,
much
yeah,
easier. So there's a
exactly.
question from Dr. Debarshi Sharma asking, can we use ORC?
Can we use what?
Debarshi,
ORC?
you want to come in? Debarshi, I see Debarshi online.
Yeah, ORC stands for oxidized regenerative cellulose. That's the same thing which we use in surgery cells or something for the
Yeah,
platelets.
yeah.
That is, I'm
Okay, okay.
talking
I
about the
got it.
platelet.
I got it. For what? ORC for what?
For suturing, to take those sutures, the platelets which you are using there.
You
You're
can
talking
use
about the collagens.
if your edges are getting. You're talking about eventration or
The thoracic surgery which you showed, the repair of the diaphragm from the thoracic
Thoracoscopic
side.
eventation, sir.
yes, yes.
Yeah.
You
So
can just
if
use
you
simple
don't have
switches
those
also.
collagens, can we
See,
use those?
in VATS, it's very difficult to do all this. So you sometimes just take simple stitches also. I think it depends upon the tissue strength. ORC may help you. We also, I haven't really used ORC because it doesn't really give you much strength. But if it gives you a peace of mind, nothing wrong in it. Because the idea is to stop the sutures from cutting through.
ORC will get dissolved with time, sir. ORC will
Yes.
dissolve with time. You want something which is
Exactly.
permanent, which will take the tension off the suture and prevent the suture
Exactly.
cutting through. So you want a
Exactly.
permanent suture material.
Till the suture, actually, I'm in the airport. I can't speak very eloquently. Till the suture gets settled there, probably sometimes when you don't have a collagen, you can probably use. We have used in some cases in all aspects. So we cut it into small
Probably,
pieces and take.
yeah.
That is why I thought that I will
I
say
mean, for
that.
want of anything, I guess you can use. Nowadays, I think they have more thicker sheets of this ORC than what is normally given. So maybe it might give you a little bit of
So
a.
Another
you,
issue is that with ORC, the additions can be also a little more than with what with collagen or those
so the
biological
cardiac
initiatives.
surgeons, sir, these days have this PTFE felt available, which you can cut into
Absolutely.
strips and use
That
that
is
rather than
probably the
taking
ideal
small
thing.
pieces. I use that for the crural repair quite often when the crural are bad. So one more thing
Can I
that we are
ask?
seeing,
Can
I
I?
want your opinion on this, Dr. Parshad, is we are seeing, I've seen about 5 patients in the last 1 year who come with a blown out myotomy following a poem. Like your patient on the CT, it looks like a pseudo diverticulum, epiphrenic diverticulum. When you go in, you find there is a residual gastric muscle fibers. I've seen about 5 in the last 1 year. I've operated on 3 of these. What do you do for that pseudo diverticulum like thing that you
I
see,
think it
epiphrenic?
will do the same thing. Diverticulum will be because of even in earlier times we have seen this. If somebody does too much of dissection on the esophagus, sometimes and the distal obstruction is not completely gone, the principle is same. The principle of managing any diverticulum is to release the distal obstruction. If you release the distal obstruction, most of the time it will settle down
So,
by
but in
itself.
a true pseudo diverticulum, we not only relieve distal obstruction, but we also do a staple diverticulectomy because they get a lot of
So even
regurgitation
in
and
so it depends.
aspirations.
I think it depends upon the size of the diverticulum.
Sure.
Small size diverticulum, even the textbook says first thing you relieve the thing and see what happens.
Sure.
If it kind
Sure.
of disappears, that was the principle even for Zenker's diverticulum. You just
Sure.
do a
Sure.
myotomy and then it would kind of disappear. But if it's very large and food is collecting in it and all, of course you will have to.
So the other thing we've been doing recently is, and we've published, is to instill ICG into the
Yeah,
esophagus. And
yeah.
particularly for a redo case, we find that when you divide the myotomy, the mucosal tube is beautifully seen green. We have a publication on this this year.
I think I
That
did,
makes
or
that
maybe
makes
I kind of reviewed it probably.
right. Oh, you are the reviewer, is it? Okay, thank you for accepting it.
I'm
So
aware of it.
So one more thought that in your pericardial, the hernia when the stomach had gone in a separate defect by the side of the left cruise, you
Yes.
took that angle of his stitch like a door.
Yeah. Angle of his.
My thought is why not also do anterior gastropexy? Take 5 sutures along the greater curves to prevent. Basically, you want to do it to prevent migration of stomach,
Yeah.
not so much to prevent reflux.
Yes, I think it was the spur of the moment decision. I know there are now studies which are suggesting that gastropexy, but they are all in the
Yes, sir.
context of a large paraesophageal hernia.
Correct,
Not in
sir.
the other. Second thing is ki my own personal philosophy is do the minimum uh, and then see what happens. In a very complicated scenario where you've already done 5-6 hour dissection, you add another tube to it. We have seen some problems related to gastropexy also. So then it's sometimes better to do what you can do. See, you have to see what is the downside, whether you are leaving something behind which can produce fatal for the patient, in which case you will do everything. Otherwise, I think sometimes we have to take a chance. And gastropexy for PH now, there is a recent study also which has suggested that it may give better outcomes in the long
So
term.
our unit policy is if patient comes with reflux, we do fundoplication. If they come with PH with volvulus stomach, we only do sutured 5-point gastropexies. We don't do fundoplications for these patients.
Yeah, that's quite accepted.
Dr. Rajdeep, Dr. Nautiyal, anybody else would like to ask sir anything? We are in such a wide variety of cases. So absolutely amazing repertoire. Deboshi has his hand up.
Yeah, regarding the endoscope while doing it robotic, do we put it there for getting that haptic feedback, little bit of feedback?
No.
Because
It's just
or
that no. See, when we do it robotic, you want to depend less and less on others. So if you have the endoscope there, it'll keep the esophagus straight.
the
Otherwise,
same thing
somebody
happens in the lab also. You can put the
no a
esophagus there,
lab.
have an
See,
endoscope.
so during laparoscopy, one of my assistant is holding one edge of the myotomy,
Okay, you have a
and
less
with the
port.
left hand, I am holding the left edge of the myotomy, and with my right hand, I'm cutting through. Right now, here you can't rely on assistant because he's far away. He's in very difficult
Okay,
position.
got it, got it.
He's trying to get his. So if I rely on him, and if he starts, best is keep the endoscope. It'll keep the esophagus straight, and you.
Fix
So I've
stomach
seen
and
some
the
of these
esophagus.
Sages videos where they put lighted bougies. So the minute you put your scope in, the lighted bougie makes this prominent. I think it'll do the same thing that your endoscope will do.
Yeah,
A lot of
exactly.
Sages videos actually have that. I have not used it myself.
But you see, endoscope advantage is we always do endoscopy before ecclesias or these things. And in ecclesias, we see the resistance. Then we leave the endoscope in the esophagus about 5 centimeter up. Because once you have endoscope in the mediastinum, in laparoscopy, the dissection becomes more difficult because it is a rigid structure and you have to work around it. Whereas in with a robo, you are a little, it can handle the thing better. And in myotomies, it just makes it stable and you can work on the thing without thinking too much about it. That's
Sir,
all.
one question, sir. So during Haller's myotomy, you was using the hook. So what is your experience the harmonic? I prefer harmonic, but sometimes it's difficult to pull the fibers. It is easy with the hook,
No,
but just the
harmonic for
perforation.
robotic is not a good instrument. It only goes in one direction,
Okay.
right? For laparoscopy, it is very good instrument. But for I use hook even for open most of the times.
Okay, sir.
But robotic harmonic is not very good because it goes straight, and if your angle is not good, you will not be able to manipulate it.
Manipulative.
So if everything is in the line of your harmonic, you may be able to use it. But if it is not in the line of, and many esophagus achalasia patients and all do not have. Nowadays, we most of the time what we are getting are hugely dilated esophagus, sigmoids, because the easy ones the gastro guys want to do poems and all on. So you may not get a right angle also. I don't think harmonic is, unless you have a pristine, you know, a virgin kind of a ecclesia where everything is going in the same line.
In laparoscopic, sir, which we will recommend? In laparoscopic, sir.
In laparoscopy, I'm comfortable with the hook, but if you have a harmonic, it's also you keep the white side down.
Yeah, white side down that. But
Keep the white side down. Once you have that plane, once you create initial plane, submuscular, I would say, between the mucosa and the muscle, then what I in laparoscopy use is take a blunt forceps, gently put it, create a little bit of space. Once you have that space, then you can keep dividing, creating the space with your lower jaw. But before I touch it again, if I use it, I always put it on a wet gauze so that its temperature comes down. If ever your harmonic has touched your finger, you will realize how hot it is. So you make one stroke, then I touch it with a wet gauze so that temperature comes down. Then again with the lower jaw, you can make. It's easy to go up with the harmonic,
Yes,
not
sir.
so easy to come down.
That is the difficulty, sir.
Lower down, the fibers are very thin. I have patients where I have done from below up with harmonic, but the fibers down, if you saw the video, were very, very thin. So harmonic may be too thick a thing for those fibers.
Yes.
And you
So
do
what
not.
is your
Sorry.
So what is your thought process on young patients who come with sigmoid esophagus? What do you recommend them in your unit?
We have, we have published this one in 2010, I think we published, and one in 2018, our experience with sigmoid esophagus. If everything else is okay, we would go for a myotomy first. Explain them that the chances may not be as great as if you did not have a sigmoid. But what we try to do in those patients, try to straighten up the lower part of esophagus a little bit, more dissection. If you saw in a routine heller, I would not do any posterior dissection unless I'm forced
Sure.
to for some other reason.
Sure.
But in those patients, circumferential dissection, try to make the esophagus straight and
Right.
then close the crura if it is very wide and try to keep the esophagus straight and then do a myotomy.
And do you vary the length of the myotomy based on the type of achalasia? Like in a type 3, you do a longer myotomy when they are pan pressurized
We would like to
esophagus.
do, see, the thing is, we would like to do a higher myotomy in type 3, but you are always limited by the anatomy and your ability to reach up into the mediastinum. Every patient has a different anatomy. In some people, it is very easy to go way up. In others, it is you can only
There
go
is,
so.
Nagi's data saying that in type 3, the poem is better because they go higher up in the esophagus.
Yes,
They
but
published from AIG and
I
NGM
think
last year.
poem guys will also come around slowly and slowly. Early days.
Yeah. So now, in fact, I was in AIG 2 weeks ago, and they were talking in terms of now doing short myotomies because
Yes,
they're seeing these
exactly.
blown out myotomies. All these years they were better than us because the myotomy was long, and now
Yes.
they're seeing bombs, and now they're
Exactly.
shortening the myotomy.
Yes,
So the
yes.
wheel is turned full circle now.
Exactly. They'll come around slowly.
Dr. Arun, Dr. Arun Kumar, we may have a call on him. Is any comments and questions?
Dr. Arun Kumar, are you with us?
Hi,
Yes.
sir. Hi, hi.
Hi.
Actually, I was enjoying the entire spectrum of surgeries from sir. I mean, it's starting from hernia to complex procedures with the diaphragm, and really enjoyed it. It was a very great evening.
Thank you, sir.
Lots of take-home points and wide variety of cases. It was not just a simple topic, and especially the ventral tap. What I find is the E-tap and ventral tap is generally a bit difficult for laparoscopy, but sir was doing it at very easy in robotic.
Thank you, sir.
And especially we can save some money regarding the mesh also.
Yes,
And
sir.
especially that's absolutely wonderful. Thank you so much, sir, for the
Thank you, sir.
variety of cases that you showed us. Thank you so much.
Thank you, sir.
Dr. Arun Kumar is Professor of Surgical Gastroenterology in Trivandrum, just for the sake of the audience who hasn't met him.
Right, sir. Very
Rajiv, sir, any final points? Or do you want to do a vote of thanks? Before that, do you want to give the audience a little preview about what the MMAS Upper GI? Dr. Rajinder Prasad is going to be the host at AIMS, New Delhi. So do you want to just briefly tell the audience about the MMAS Upper GI, Dr. Rajiv?
Yeah, we have all the programs which are upcoming. We have a number of slides for that. So before we go on to that, Dr. Prasad, I would like to ask a few very simple basic questions. So a person like, for example, me, who is unlikely to get access to a robot, should he undergo robotic training? One. Secondly, for a surgeon, should he get access to a robot first and then start training, or should he start training and then go for a robot?
So, sir, what I think is how I started was I didn't know whether I'll ever have life. You never know life. It may present it to you tomorrow. So simulation training, you should always undergo. It gives you a experience with the machine and all. And, it gives you how to go about things. But once you have the robot, it's always better to have assist few cases as bedside. But you must, for simulation and all, you should undergo it because it will uh, give you a feel of the whole thing, and then you can shorten your time. If you get a robot, then you go straight on to as a bedside assistance with some trained person. And then on the console, the problem I have seen is people are in a hurry to sit on the console. They have never been on the bedside. They don't know the how to dock properly, undock in an emergency, and this, but they want to jump. So, but if you get an opportunity to train yourself, please do. We have that Hugo Ross training center at AIMS only. You can always come, spend some time with it. It'll give you a good perspective, and it also gives you confidence to be able to handle it once you get it. And of course, if you can go to a mentor, come to us anytime you want when we are doing these procedures. You're most welcome. But I think getting trained is always welcome. You should always get yourself trained.
Because I also believe that robotic is the future. So if anybody wants not to be left behind, then he should learn robotic as soon as they get a chance. And Amasi is also coming up with the robotic programs. We are still in discussions. Probably by the 2 or 3 months, we'll be coming out with the robotic training programs also.
Yes, sure, sure. I think it's always a good idea.
So, Prabhu, could you please share the slides of the upcoming programs? So, our flagship program, the Massicon, is in Jaipur in 28th to 31st of August, and you'll have a very wide variety of operative procedures being demonstrated there live, as well as master videos, a whole lot of discussions on the latest upcoming things. So I request everybody, all the viewers, to do join in. Next, please. We have the Massey Lens program every month, and on the 17th of April, we'll be showing the laparoscopic CBD exploration from 7 p.m. This will be the practically unedited demonstration master video with the operator there to answer all your questions. I suppose this is the best option anybody has for clearing their doubts about CBD exploration. Next, please. The Amasi online CME series, what we had today, the next month is on management of recurrent rectal cancer. And Dr. Arthur Harikrishnan, who is the president-elect of Association of Coloproctologists of Great Britain and Ireland, would be speaking at 8 p.m. on the 1st of May. The 112th Amasi skill course will be at Parul University, Vadodara, Gujarat, 25th to 27th April. So anybody in that area, please join in. The MS hernia is upcoming in Jaipur, the Rajasthan International Center. This will be on the 23rd or 25th May. And as you know, we have a 3-day online also. And you can see from Dr. Rajinder Parshad presentation that he is an very wide experience in upper GI, very advanced procedures, and he'll be the chairman, the organizing chairman for the MS in upper GI and bariatric surgery, the 9th to 11th June, and then the physical from 13th to 15th June. So the course registration is online, and Dr. Patankar is going to be the national director for that. The detailed program will be available in a couple of weeks. Thank you very much. And it's my pleasure to thank Dr. Rajinder Parshad. He actually had a very short period. In fact, last week I had discussed with him whether he'll be able to present, and he more than excelled in it. There was such a wide variety of cases. We are very much thankful to you, sir, for this presentation.
Thank you, Dr. Rajdeep.
I have pleasure in thanking the moderators, Dr. Roy Patankar from Mumbai, Dr. Hemant from Dehradun, and Dr. Arun Kumar from Trivandrum. So we have covered practically the whole of India from Dehradun to Trivandrum. And thank you very much for moderating this session. And it's nearly 9:30 now, 1.5 hours already, and it's still, I feel like I want to listen more and more to your lecture right now. Thank you very much, everybody, and all the participants, the delegates. And last but not the least, I wish to thank Merrill, who are the sponsors of this online CME program. Thank you very much, sir. And I believe Merrill team has a video to show.
Thank you, Rajdeep.
Thank you. Thank you very much, sir.
Okay.
Merrill, are you coming online? I think.
With your permission, maybe can I leave because
Yes, sir.
Recording
Prabhu,
stopped.
close the meeting.